We have an international speaker, Dr. Naveen Vasudeb, who will be speaking on clinical genomics in prostate cancer management. May I request Dr. Partho Dasgupta sir, Dr. Abhay Kumar to come on the dais to chair the session and introduce our speaker.
Good afternoon. Our next topic is clinical genomics in prostate cancer management. And speaker is Dr. Naveen Vasudeb. He is consultant Leeds Cancer Centre, UK. And Dr. Naveen Vasudeb, please.
Excellent. Okay, so thank you very much. Indeed, it's a pleasure to join you all virtually, and thank you very much indeed for the kind invitation to speak to you this evening. So the topic is clinical genomics in prostate cancer, and of course this is a very relevant topic, I think, very current, particularly given the story around tumours with a BRCA mutation and their increased sensitivity to PARP inhibition. But yeah, I think this is a story that clearly goes beyond just that in prostate cancer. I treat kidney cancer as well, where the genomics of that disease are also very well defined, but there are actually a few directly sort of actionable mutations in kidney cancer. But prostate cancer seems to be different, and hopefully just sort of show you that I think genomics has the potential to impact throughout the spectrum of prostate cancer. So I think this figure that I've stolen illustrates that quite nicely in terms of how we might sort of better personalize the approach taken in patients. I've been listening to, it's been an excellent the sessions that I've listened to around how we choose approaches to patients, but perhaps there's a role here for genomics in certain settings. For those with indolent disease, how do we better avoid over treatment? I mean, we are much better at it now, but we have got to admit that clinical factors alone will only take us so far. Even in those who we offer curative treatment, what should the intensity of that treatment be? But really, I'm going to focus on those who present or develop with lethal prostate cancer, metastatic disease. In these patients, well, perhaps, how do we better use the drugs that we already have? But of course, in particular, how do we exploit that genomic information for patient benefit? So before I get into sort of the meat of it, I thought that it was relevant to just mention these gene expression arrays that are out there. These have been around for a while now, and they're pretty well validated. And these are the big three, I think, the Decipher, Polaris, and Oncotype. I think as I've put extracts from the EAU guidelines, but I think all the guidelines would say something similar, and that is that these aren't going to be useful in all men with localized prostate cancer, but there is certainly perhaps a place for them, particularly thinking about men who end up being classified as having an intermediate risk disease, and can these genomic scores help risk stratify those men. I have to say, certainly none of these tests are commissioned within the NHS. But turning to what I was going to really concentrate on for the next few minutes is rather than gene expression, but in terms of DNA aberrations, amplifications, mutations, etc. And you can see that the genomics of this disease is very well defined now, and you can see how the landscape evolves as one moves from the localized setting through to castrate sensitive and then resistant disease. And one can see as one moves from left to right, not surprisingly, we see amplification of the AR gene, but then these events that we kind of associate now in this disease, the defects in DNA repair, cell cycle progression, these events are beginning to accumulate and become much more common. You know, there are certain events that do tend to or can occur early, like TP53, and we know that if that is occurring early, it's a poor prognostic factor. And sticking with the idea of prognosis, I thought it was important just to focus on BRCA1/2 for a minute, you know, given the prominence of those genes now in this disease, and to think about what's the prognostic impact, first of all, for those men with tumours deficient in BRCA. So this is a nice bit of data, I thought, over 700 patients from a study called Capture. And none of these patients were exposed to a PARP inhibitor. So it's really looking at, you know, how do these men fare when exposed to the standard treatments that we already have in the cupboard. So about 11% were BRCA2 deficient, 3% BRCA1 deficient. And on the panel on the right then takes you through how those men fared. The blue and the orange representing PFS1 and PFS2, and then the grey bar out to represent overall survival. And you can see that the men with BRCA deficient tumours fare worst. And then next are those who are non-BRCA but still have a mutation in one of the HRR homologous recombination genes. And then those that are doing best actually who are proficient in HRR. But of course, what the real story here is around the predictive ability of BRCA, and this data will, I'm sure, be familiar to many of you. So this was the profound study, and it was a study that randomized men 2 to 1 to either olaparib PARP inhibitor or a switch to Enza or Abi. Of course, that control arm that we've now seen repetitively in studies, and I think quite rightly has come under a lot of criticism. But that's where we're at. So that was the control arm, and what we can see, the study was in 2 cohorts. Cohort A, those men had tumours with a BRCA1, 2, or ATM deficiency, and then cohort B with much rarer but other mutations involved in DNA repair. And you can see the benefit here was limited to patients in cohort A. This is for overall survival. And it's worth noting that the majority of men in the control arm were allowed to cross, and indeed did cross over to the PARP inhibitor. So BRCA1, 2, and ATM. But what we've gone on to learn is that actually not all these events are equal in terms of predicting benefit to a PARP inhibitor. And if we look instead at the Triton-3 study, this is a study with rucaparib now, very similar design. And what we see here is actually that the benefit is actually now being limited to those with a BRCA mutation, and those in the ATM subgroup are not showing any benefit over that control to PARP inhibitors. So perhaps this benefit more limited to BRCA. We've gone on to learn more still. And in fact, this data on the left panel, I mean, small numbers, one has to admit, only 13 BRCA1 mutated tumours there, but a suggestion that actually BRCA2 portends a better outcome to PARP inhibition than BRCA1. And then smaller numbers still, a Triton-2 study, but again reinforcing the story around ATM, but also other genes like CDK12 and CHEK2. Now, the panel at the very bottom right was just lumped together some of the other rare events, but there were responses seen there And so I'm hearing from colleagues that events such as in genes like PALB2 would be are sufficient to encourage them to use a PARP inhibitor in tumours with deficiencies in genes like that. I think the thing to remember, though, is that even if you have a BRCA1/2 mutation, the data suggests a PARP inhibitor on its own, you're still looking around a 50% PSA response rate, a PFS in the region of 7 months. So you know, it works, but certainly not in everybody. And I just thought this was interesting data. I mean, this is a subgroup of a subgroup. So these are patients with both SPOP and BRCA2 mutation. The small numbers, but it does seem that this carries a much more beneficial response and durable response to PARP inhibition. So you can see the time on PARP inhibitor is 24 months versus 8 months. But the numbers, you know, again, are very small here, and one has to bear that in mind. And this is all very well, but of course we have to actually establish the genomic status in these patients. And there are challenges there around the practicality of this. And a lot of this data I'm showing you is from the PROfound trial. So there are 4,000 men screened for that. So we can learn a lot about the success of next generation sequencing. And not surprisingly, then, things like the age of the tissue that was subject to sequencing is relevant in terms of the success. So the older the sample, not surprisingly, perhaps the less likely you are to return a successful profile. And indeed, even where that tissue came from can impact the success. So tissue from bone, for instance, being the least likely to return a successful profile. On the panel on the top right there was an attempt just to illustrate, because of course there's a question around if you're using tissue from the primary tumor, for instance, and that may be, you know, from several years ago, might we miss a somatic mutation in BRCA1 and 2? But actually the data, and I've shown you as well that these events are accumulate, seem to be more prevalent in later stage disease. But it does seem from the data that it's not a huge amount of data, but from the data that out there, we're looking at in matched specimens, that actually there is a high degree of concordance, and it seems therefore that those patients, men who are destined to do badly, these events actually do occur early. And then finally, what about if you can't get any tissue at all, or the tissue has failed? Are there any alternatives? And again, we've seen this from PROfound, is there about 500 patients where they looked at ctDNA. And in fact, there's a very high concordance between tissue and plasma ctDNA. So that may provide a feasible alternative route to establish the BRCA status. And I thought I would just share with you the current UK guidance that we have for BRCA1 and 2 testing. So eligibility, well, you have to have castrate-resistant prostate cancer and be eligible for a PARP inhibitor. But the germline analysis should only be reserved where, you know, there's insufficient tissue for somatic analysis, or that analysis has failed. So naturally, we'd start with somatic analysis. You'll miss many of them if you only look in the germline, obviously. In terms of the sample, well, they say that the sample should be less than 5 years old, a 20% tumor content, and a note around if you're using tissue from bone that it's correctly sort of decalcified. Germline testing is recommended in men under 50 with prostate cancer, or under 60 with metastatic disease, or of course those with a family history. But as I say, this story goes beyond just BRCA And so there are other events occurring here. Sometimes they're very low frequency, admittedly, and this is the case here. But not surprisingly, as we've seen from other tumor types, such as lung cancer, that if you have if the tumor has a high mutational burden, or if your tumor is deficient in mismatch repair or is high microsatellite instability, then these tumors seem to respond better to immune checkpoint inhibition. We know, of course, if you take all comers, the response rates are low, but there are patients out there at low frequency, admittedly, but if you look, you could potentially find these men who are going to respond well to checkpoint inhibition. What about those men with an ATM deficiency? We've said that that ATM doesn't necessarily predict for a good response to PARP inhibition. This is still very early data, one has to admit. That figure I'm showing you on the right is preclinical data. It's a mouse model. But the idea is that so ATR and ATM sort of collaborate, as it were, to recognize DNA damage, particularly single-strand break. So the idea is that if you inhibit ATR when you've already deficient in ATM, there is some degree of synthetic lethality there. And if you add in PARP inhibition as well, then the effect seems more profound still. And that was sort of borne out in the figure on the right. So this is still early, but certainly these ATR inhibitors are now in phase 1, phase 2 studies. So I think we're going to hear more about this story in the coming months and years. And then my penultimate slide and the story around those men whose tumors are PTEN deficient. Now, so if you recall, PTEN is a tumor suppressor gene which acts to downregulate signaling through the PI3 kinase AKT pathway. So obviously, you've lost PTEN, then AKT is sort of constitutively activated. And so now, how you define PTEN loss seems to vary. Depends on the assay that you use. But in this key studies to date by Chris Sweeney, they used immunohistochemistry, and they actually almost half the patients they defined as therefore having.
Sorry to interrupt. As you're running short of time, can we wrap up in a couple of minutes?
Yeah, it's my penultimate slide. So I'm going to, in fact, I'm quite happy to sort of wrap up there. So, I mean, I think this is a story around how we better personalize care for patients. I think it's a story that's going to move earlier into the disease spectrum and in the hormone sensitive setting as well, potentially. But there are some challenges, as I've highlighted. So I'll stop there and thank you very much for your attention.